In this lecture, we will be discussing about the coronaries of the heart. Now, we should be knowing about certain structures. First of all, we should be knowing about the main vessel that supplies the heart. So, this is the aorta that arises from the LV outflow tract, and then it gives branches the left system and the right coronary system. These arteries arise from these sinuses as being shown over here. So there are left coronary sinus which give rise to left coronary system, and similarly there is the right coronary sinus that give rise to right coronary artery. So this is the basic framework of how these arteries arise. Now let's just discuss in detail regarding each of them. Now let's discuss the left system first. So as we can see that the aorta give rises to this structure which is called left main stem or LMS. So this left main stem is a branch of the ascending aorta as being shown over here, and it arises from the left coronary sinus just above the aortic valve which lies over here. It is basically 5 to 10 mm in length before it gives branches of left anterior descending and left circumflex. So we can see here this is the left main stem and this is bifurcating into two branches. Now this is what we call as the fluoroscopic anatomy of the vessels. So the cardiologist, when they want to look up the arteries, they shoot up the arteries with a catheter engaging the ostium of the vessel, and then they give the dye to delineate the vessel's outline. So this is being done over here. So this is what we call as the engagement of the left main stem. So we can see that this is the catheter and this is engaging the left main ostium, and as you can see on your right hand side, this is the left main ostium and the stem. Then this is the left anterior descending artery called LAD, and this is the left circumflex artery. So this view is called a caudal view, and this view helps in evaluating the branches as well as the left main stem, and any disease can be found if there is any. Now let's discuss one of the important artery. It is called a left anterior descending artery, and it is a branch of the left main stem. So it is the largest coronary artery because it supplies the majority of the heart musculature. It runs into the interventricular septum. So this is the interventricular septum, and this give rise to some branches which are called septal branches and the diurnal branches. So septal, as the name suggests, goes towards the septum just like over here, and the diurnal branches supplies to the lateral wall. So we can see some diurnal branches over here as well. Now let's look at the fluoroscopic anatomy. There are different views to look up the arteries. So there are views called caudal views and the cranial views. This is just based on the transducer location. So the thing is that we do not want to miss any part of the artery who is having the disease. So the main aim of doing all these angiograms is to pick up the lesions at any part, and we do not want to miss that. So this on view on the left hand side is called the caudal view being shown over here, and the one on the right hand side is called the cranial view. Okay, so both of these views are showing the arteries of the left system. Now we want to have a look at the LAD. So now if we can see on the right hand side that this is the course of the left anterior descending artery. Okay, so it's a very long artery. Now it gives some branches as we have discussed before. So these branches are called the septal branches because they goes towards the septum, and the other branches are called the diagonal branches because they go towards the lateral wall of the heart. So these are the two major branches. So there are multiple branches for the septal as well as diagonal, and there is a lot of variation in that. But both of these branches are present, they vary in the number. Now the artery itself is further segmented based on anatomical landmarks. So there are three portions of left anterior descending artery. It is the proximal segment, the middle segment, and the distal segment. So what demarcates the proximal from the middle is the first branch of the septal perforator. The middle segment lies between the first septal branch, and it represents the halfway point between the septal branch and the ventricular apex, and the distal segment is after that halfway point towards the apex. Now let's look at this on the fluoroscopic views. So now we can see is that this is the proximal LED. Now these lines have shown you the demarcation for this LED. So anything behind this line will be proximal LED because this is the first septal perforator that was coming from here. And now the mid LED, as we discussed, it lies between halfway between the apex and here. So the halfway point will be somewhere here. Anything from below downwards from here will be the distal LED. So this is how you classify the LED into segments. There are lots of variations for LED. So based on that, it has been divided into four types. Type 1 is when the LED doesn't reach the LV apex. Now we can see this, that this LED is reaching the LV apex. You can clearly see that. So anything if it doesn't reach to the apex will be the type 1. Now what will be type 2? The type 2 is it will reach to the apex just like as in this case, but it supplies a portion of that, and the rest of the part of the apex is supplied by the RCA. The third type is when all of the apex is supplied by the LED and nothing is contributed by the RCA. And the type 4 is that it supplies the apex and then it moves around posteriorly and also supplies the 25%, more than 25% of the inferior wall. Now let's come to the other branch called left circumflex artery. So it's again a branch of the left vein stem. As we can see over here, this is the left circumflex artery. It runs in the coronary groove. The AV groove goes towards the left heart side and also goes to the posteriorly and supplies that area. Now this is another view showing the course of this left circumflex. So this is the left circumflex. Now as you can see, this is the lateral wall and now it's going posteriorly over here. And this is another view showing that. So this is the posterior surface of the heart and the left circumflex is going over here. So why it's called the circumflex? Because it rotates or moves around in the groove. So that's why it's called a circumflex. So it has gained some variable course. Sometime it reaches the crux of the heart. And now what is the crux of the heart? The crux of the heart is basically this point. So crux of the heart is defined by a space that is located in the posterior and the septum. So this is posterior and this is the midline portion called the septum and is bounded by the different chambers, the right atrium, the left atrium, the RV and the LV. So this is the RV, this is the LV, okay, and this above the LV is the LA and this is the RA. So this is the space which is very important space. It's called the cardiac crux. So as we can see in this case, the left circumflex didn't reach towards the crux. So but it has a lot of variability again. Sometimes it reaches, sometimes it doesn't. This is the fluoroscopic anatomy of the left circumflex. The left circumflex is being seen over here. This is the root for that left circumflex. Now the circumflex is divided into two portions, the proximal segment and the distal segment. It gives rises to some branches called the obtuse marginal. So this can be a number of branches. Over here we can see two obtuse marginal. This is the major or the larger one, and this is a smaller one, but these are two branches which can be seen over here. There is a concept of a dominant system, so it can be either left or right. So in the case of a left dominant system, there is a branch called a posterior descending artery or a PDA, which runs into the posterior interventricular groove as being shown over here. So if it arises from the left circumflex, then it is called a left dominant, while in the case of a right coronary artery giving this PDA, then this is called a right dominant system. In majority of the population, in 70 to 80%, the RCA is the dominant vessel, while in 5 to 10% it is from the left circumflex, while 10 to 20% this PDA is given by both the left circumflex as well as the right coronary artery, so it is called a co-dominant system. Over here we can see that the circumflex is not coming over here towards the crux and giving this PDA, so it is the right coronary artery which is giving this PDA, so it's a right dominant system. Now on the fluoroscopically, how will you see a left dominant system? It is being shown over here. So we can see that this is a left circumflex artery, and this gives rise to this PDA over here. So this is the PDA which is being given over here, and it runs towards this area. While look on the right hand side, this is the left system which is non-dominant because the RC is giving the PDA. So over here we cannot see any PDA. Okay, so this is an important concept. Now let's discuss the right coronary artery. So this is the right coronary artery coming from the right coronary sinus of the aorta. What is the anatomical course for the right coronary artery? So after arising from the right coronary cusps, it goes towards the right side and then goes posteriorly and inferiorly. It travels between the right atrial appendage and the pulmonary trunk and then goes into the right AV groove. It then moves around inferiorly in the groove and then reaches towards the cardiac crux. So here we can see that it's moving in the AV groove and reaching towards the cardiac crux. In the crux, sometimes it goes towards the left hand side and connects with the left circumflex artery. However, we cannot see it over here, but usually it goes around and then have a connection with the left circumflex. This is the route for this artery. Now this is the fluoroscopically identification of the right coronary artery. We can see that this is the catheter engaging the right coronary artery. So now let's see that how it looks like in real motion. The right coronary artery, we can see that it is divided into three segments, the proximal, the mid and the distal, and it gives rise to many branches. So there are a lot of branches arising from the right coronary artery. So the initial branches are the sinus node artery branch being shown over here. It goes and splices towards the sinus node. Then the RV marginal branch or RV branch over here, you can see that, and it is one of the important branches because it supplies the right ventricle. So whenever there is inferior wall infarct because of RCA and especially the proximal infarcts, then the right ventricle is compromised because this artery is occluded. Now over here is the crux which we have seen before on that 3D. At the crux, it divides into PLV, posterolateral branch, and the PDA. So we know that PDA is that branch which comes around the crux and then goes into the posterior interventricular groove. So majority of cases the RCA gives this PDA and it is being shown over here. And the other branches is the PLV which is being shown over here. Now let's discuss the supply, where these arteries supply and which part of the heart. The left anterior descending artery, the septal branches supply the anterior two-thirds of the septum and the bundle of his. The diagonal branches supply the anterolateral wall and the papillary muscles, especially the anterolateral papillary muscles. So these are the supply for that vessels. The circumflex supplies the posterolateral section of the left ventricle. So this is posterior and this is the lateral. So now the right coronary artery supplies a very large area, especially on the right side. So it involves the anterior and the diaphragmatic surfaces of the right atrium as well as ventricle. Along with that, the posterior two-thirds of the interventricular septum. Now it has a lot of branches as well. The conus artery, although we cannot see that because it has a very variable origin. Sometimes it arises from the right coronary artery, but it also arises separately as well, and this is the most likely route for that. Okay, so the conus, when it rises, it goes like this. So it supplies to the infundibulum of the right ventricle. The sinus node artery supplies to the sinus node. The RV marginal branches supplies to the RV, and again it is a very important artery because in the case of inferior wall infarct, especially proximally, if this artery is occluded, the RV gets infarct, and the management kinds of get a bit different. The PDA, very again important artery, it supplies to the posterior one-third of the interventricular septum. The right posterolateral artery supplies to the left posterior atrium and the ventricles. And finally, the AV nodal artery. The AV nodal artery again has a bit of variable course. However, in majority of cases, it somewhat arises from here and then supplies to the AV node. But again, it has a bit of variable course. So this is the supply of the right coronary artery. So this was all for today.